Good afternoon and welcome everyone to the third of our series of webinars at the Dalalana School of Public Health. I hope everyone is keeping safe and well and that all of their families are safe and well. Today we are focusing our attention on issues with respect to health disparities that COVID-19 has exposed among marginalized populations in Canada. But before we begin and before we introduce the panelists, I'd like to start with a land acknowledgement. So I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So it's my great honor to introduce our speakers for today. We're very privileged and pleased that they took time from their busy schedules in working on the COVID response to be with us today. So Angela Mashford Pringle is an assistant professor at the Dalalana School of Public Health and the associate director of the Wakabenas Bryce Institute for Indigenous Health. Kate Mulligan is an assistant professor at the Dalalana School of Public Health and director of policy and communications for healthier communities. Roberta Timothy is an assistant professor at the Dalalana School of Public Health and a health scholar and mental health practitioner. And Andrew Pinto is an assistant professor at the Dalalana School of Public Health, a public health physician and the founder of the Upstream Lab. So welcome everyone and thank you for being with us today. COVID-19 has exposed some of the clear delineations between different social groups and how they're faring in this new world. Can you tell us what these groups are experiencing? And Angela, I'd like to turn to you first.
Sure. So for First Nations, Métis, and Inuit people, this is definitely a major game changer for us. From the fact that we can't do our normal hugging when we greet each other, to the fact that we can't have our ceremonies. So a lot of our ceremonies we've been asked to not have, like our sweat lodges. Obviously, we're not seeing each other, but we have managed to do virtual powwows and shout out to all the jingle dress dancers out there who managed in the middle of all of this to go outside and do their dancing for everybody, which I thought was fantastic and it was wonderful to watch. From the littlest dancers to the biggest dancers, it was fantastic. But the other thing that we need to be cognizant of is we were already in colonial issues that haven't been resolved and are now actually going to be further exasperated because of this. For example, the lack of usable water in our communities. Some are on boil water advisories, some are on the fact that you can't, do not consume advisories, which means you can't hand wash like you're asking people to do, and that's problematic all to itself. We also have overcrowding in our houses, so when they start talking about social distancing, that's almost impossible to do in some of our communities where you may have 18, 20 people in a house. It's not possible or feasible. And then, we have things like the lack of protective equipment in our communities. So even though we're talking about people using the protective equipment like masks, they may not have opportunities to have them. They may not be there. And healthcare was already a problem before this all began, and it's going to continue to be a problem. We don't have respirologists or epidemiologists in our communities to take a look at our statistics and to help our people when it comes to getting ill. So the opportunity of further advancing the disease is going to happen because we don't have all of those things. And then when I start to think about the social aspects, we do have homeless here in the city. So let's talk more urban. And of course, they are now isolated from other people because you're not supposed to be with any distance. So where we may have had couch surfing before, we'll have nothing because they can't do that. And then with people confined inside houses, we already know that we're going to have an increase in domestic violence and child abuse and child neglect. So these things are all coming to a head, and because often Indigenous people have poverty issues, especially when you live in a city, where are you going to go right now? You're not supposed to be outside, or you're supposed to social distance. So people are having trouble with that. They can't really afford to be anywhere else. They may be struggling with food insecurities because, in a normal day, they probably were already struggling, but now you're telling them that they have to stock up for a week or 2 weeks, and that would be next to impossible for them on the funding that they have. Even if we said there was a rent moratorium, they're likely to still have issues in terms of having money to buy what they need. That's all to say that they don't get sick. So if anybody in their household gets sick and you need other medications, or somebody in your home's going to be in the hospital for any length of time, what does that mean? For fly-in communities, that's even worse. Chances are it's only one person flying out, and you're going to spend your time in a hospital by yourself. And that's going to be tremendously hard if anything happens negatively. If we see deaths, that will be really hard because we won't be able to practice our normal rituals after death. And then same thing goes if you're living in the city, you may not have access to your kin. So we have kinship ties that aren't necessarily blood ties, and we need to be thinking about what that means. If you can't, what if COCOM doesn't have a way of being online, or you don't have the opportunity to go drop by and see the elders because your fear and your anxiety and your depression's bad, and because of the situation right now, you're not able to go out and see them. Is that going to exacerbate all of the situation and make it that much worse? So I want people to think about all of those things. I'm sure it's happening with everybody, but for Indigenous people, it's all about family and it's all about holism. And we have to start thinking about, in COVID-19, what does it mean now, and what will it mean post-COVID in terms of doing our ceremonies? What will it mean in terms of being together? What will it mean in terms of trying to be holistic? And I think, I talked about this in other places, but I really think it's time for us to start thinking holistically. Instead of thinking about, capitalism and the almighty dollar, we have to start thinking about people as people, not as dollar signs. And that's part of where we need to go.
Great. Thank you, Angela. Kate, would you like to speak from the perspective of the populations that you're engaged with?
Yeah, I would love to. So at the Alliance for Healthier Communities, we do community health by and for regular people, including marginalized populations, in community health centers, in Aboriginal health access centers, nurse practitioner-led clinics, and community governed family health teams. So these are organizations that provide health and social services to the people and places that aren't very well served by mainstream healthcare. So we've been working on a number of issues, and certainly indigeneity and racialization and Black health have been very top of mind for our membership, but I know Angela and Roberta can speak to those very well. We are also working very hard on behalf of people who use drugs. This pandemic has exposed the idea that some people are more expendable than others, and people who use drugs often find themselves on the bottom of this list. And so we need to make sure that, like everyone else, those who are using drugs have a safe place to self-isolate or socially distance, physically distance, have a safe access to prescribed opioids and a safe supply, and that the people who work with them also have the personal protective equipment they need to do this vital and important work. These are people who are facing a double crisis, the opioid crisis and the COVID crisis at the same time. And so they require quite a bit more intervention. We also are working with populations like the migrant agricultural workers on whom our food system depends. They are facing increased risks as well, and are moving across borders and potentially living in crowded conditions, and require, again, a more coordinated response. We're working on behalf of people in corrections who also are in crowded conditions, calling for the release of nonviolent incarcerated people and making sure that there's a plan for their health and social care when they are released. Of course, we are also working with people experiencing homelessness. Again, people who require a safe place to be, and have required this for a long time, not just under COVID, but require it now. The United Nations has said that housing is the frontline defense against COVID-19, and it's something that is having its moment in terms of people recognizing its importance and how critical it is for overall health and well-being. And the last one I'll mention is isolated people. So seniors over 70 in particular have been very strictly asked to self-isolate, and will require lots of community supports and services to make sure that they can do that safely and well. We continue to provide primary care services to the people with complex social and medical conditions that need them, and that communities rise up together. And we're seeing lots of great grassroots examples of community action and people mutual aid and people helping each other. But we need to scale that up to a broader level of social prescribing. We need to bridge the digital divide for people who don't have access to phones or digital devices to really ensure that we can do that well.
Great, thanks, Kate. Roberta, from your perspective, what are you seeing, hearing, and what's your analysis?
Thank you. I'm going to talk about the Black population. So the Black population in Canada consists of over 1 million people. And the first most Black populated provinces are Ontario, Quebec, Alberta, British Columbia, and Nova Scotia. And we are transnationally connected, meaning that we have connections in Canada and all over the world. We have families with direct ties to Brazil, United States, for example, Haiti, Dominican Republic, Colombia, France, Kenya, South Africa. Hence, COVID-19 is heavily impacting us across borders. I've spoke to family and friends who are experiencing COVID-19 losses and fear of losses in Canada, the US, Caribbean, Europe, South America, and the African continent. The history and current day colonial realities and violence that have led to extreme health disparities due to social determinants of health and what I call health violence are real. Our communities are intersectional, meaning that we experience disparities based on gender, class, gender identity, sexual orientation, differently abled or disability, age, refugee status, religion, and spiritual affiliations, to name a few. In our lived realities as Black folks, we experience the impact of colonization via transatlantic slave trade, forced migration, and subsequent divide of African region. Before COVID, during COVID, and after COVID, Black community members are dealing with anti-Black racism and other intersectional violence that impact our health. COVID-19 is not the great equalizer because Black, Indigenous, and other marginalized groups have not started on the same equal playing field. Instead, we have had unequal access to care, have large numbers of underlying health conditions due to the impact of colonial and health violence, example, transgenerational trauma, diabetes, hypertension, asthma, high blood pressure. Black people during COVID are experiencing trauma, death. People have been talking about death, people dying, strained relationships with healthcare, health disparities, not being tested or sent home, underhoused, experience underemployment, mental and physical stresses, food insecurity, racial profiling. Wearing a mask is not safe for all of us in this community. Increased criminalization or fear of criminalization, child apprehension, and much more. Our essential workers are mainly in fields that have little power and pay, such as PSWs, nursing, childcare, delivery services, transport, and little or no access to protective care. They're also working on the front lines in shelters and community health centers where anti-Black racism, health violence continues. Not having race-based and intersectional health data has an adverse impact on our Black communities. Thank you.
Thanks, Roberta. Andrew, over to you. From your perspective, what are you seeing and hearing?
Yeah, thank you so much for having me join this conversation. And I guess a few thoughts as a frontline family doctor working at St. Mike's Family Health Team. Some of the things, just to add to what others have said, is we're really seeing people who at baseline were struggling to be really struggling even further, as many of the key resources that they relied on have been closed, shut down, or pulled away. So just to highlight a few people who at baseline are very food insecure. So many of my patients are on basic welfare or on ODSP. And as many know, this keeps them well below the poverty line. They rely on food banks and free food programs, drop-ins, and almost all of those are closed. So an already bad situation is a lot worse. We have a huge number of seniors who are very isolated at this time. And we also have a lot of folks who are dealing with complex chronic diseases that are now being managed as best as they can through a system in primary care that has mostly become virtual. So almost all of our interactions now are over the phone or through video. And I worry a lot about what this is going to lead to is kind of a pent up demand for service after, and also potentially people getting ill and staying at home and not seeking the care that they need. So that's kind of what we're seeing as a cliche. And I'll just add one thing that our lab is trying to do. The Upstream lab is trying to help people sort through all of the new programs and services that have sprung up across the country. So we have some amazing students from Dalalana, Rochelle Perrin, Jillian Macklin, and Tara Upshur, who are all assisting with this effort to, across Canada, identify all of the new social programs, volunteer-driven programs, food delivery programs that have sprung up, and actually create a single tool that people could go to and help navigate. So we're building that as we speak. The other thing I just wanted to note is the issue of that almost from the start, this response has been driven by an enormous urgency to flatten the curve, get it under control, contain it. But there really just hasn't been the consideration of the impact on different communities and population. And just to highlight one example, which Roberta touched on, which is masks. So really, what does it mean to recommend that people go out in public when they're going to a grocery store and wear a mask, but for a brown or black man to go into a store wearing a mask is something that could put his life at risk and also change the way he's treated. And and what I would have liked us to see is that as a public health community, that we would not be reactive to when communities bring up these issues. We would have been proactive. And really going forward, what we need is to take an equity lens to all of the responses. So when a decision's being made, when projections are being made, when policies around who still needs to go to work and who can work from home are considered, or who gets income supports and who doesn't, is actually saying let's consider and consult with communities made up of the most vulnerable folks and get their thoughts on this. And I'm not saying that recommending masks is not. I think it's a good decision, and I think it's something that many people thought was a good decision even before the announcement this week. But let's just think about how we can make these recommendations, but not make sure it's affecting some people in a negative way more than others.
Thanks, Andrew. So you've all raised some incredibly important and difficult issues, highlighting the fact that, the original way we were conceptualizing the pandemic was that we were all equally affected. But what's clear from what I'm hearing is that there's been a differential set of impacts that basically map along historic and pre-existing disadvantages that exist. So this might be an opportunity now for us to think, as Angela was pointing out and others, that we can think about things differently. So in light of that, what can current governments, local, provincial, and international, do to help redress some of these inequities? I'm going to start, Angela, with you. Where do you see this going, and how can we address these issues?
Well, 150 years of colonization is going to be hard to reverse. I love the fact that everybody talks about truth and reconciliation, but now's the time we actually have to put that into action. We need to talk about that truth, the truth being that our First Nations and our Métis and our Inuit populations are horribly vulnerable, not just in a pandemic, but in an everyday way. And then we need to start talking about the racism that's here. Policies and procedures, healthcare, access to anything is often affiliated with some type of racism. And people can argue that it's not, but the reality is it's happening every day. So what I think is that we need governments that will look at all things from courts to healthcare, from policy to practice. We need to start looking at everything that's out there. For example, we need PPE in our First Nations communities, and I'm not sure that it's going to get there. The borders are starting to close today for most of the Northern Ontario First Nations, and I'm not sure they have enough PPE for them to get through this, not for their healthcare, certainly not for social workers who will definitely need it, or other essential workers like police or fire or you name it, people that have to actually go into other people's homes. So that's problematic. Governments can start, looking at the conditions and trying to bring about equality. When I say that, out of the territory, like out of all First Nations territories, we still have tons of communities who are on boil water advisories, and even more that are on do not consume. And yet we're telling them, go wash your hands. With what? When you're sitting in Toronto and you're homeless, you can't go wash your hands every 5 minutes, and you are going to be touching things. So our policies, our procedures in a pandemic are only those for privileged. They don't work for non-privileged folks. And we've got to start thinking about what that means. And our policies, our funding, the way we interact, all has to go back to who the most vulnerable in our populations are. And when I say that, the other thing is housing. Housing, whether you're homeless or you're in a First Nation, and trust me, First Nations definitely need housing. We have to start thinking about what that looks like. What is a house? What is a home? Some of the work that I've been working on, looking at the difference between what is a house and what is a home is important. We're all sitting in our nice bubbles in our homes, but a house would just be that, shelter over top of you. That doesn't make it a home. There's placemaking issues that we have to talk about. What makes it so that you feel comfortable going there? And governments need to be thinking about that, not being in our bedrooms, but rather making sure that the policies that we purport to say that our society is so equal actually are equalizing, and that the vulnerable populations feel like they have a home, not just a house over their head. And even then, I have to say, we have so many homeless people across Canada that we really need to be starting to think about that. Why is it that we have homeless people? These are not people who chose it. These are not people who just by the sheer decision of, doing something, one behavior, ended up homeless. Often it's of no fault of their own that they end up homeless. And I think that we tend to forget that. So I think the governments can, start looking at it now during the pandemic, because when we come post-pandemic, it's going to be really, really important to make these changes. I also think it's very important for us to start thinking about relationships between First Nations, Métis, and Inuit people.
Great, thank you. Kate, what would you like to see in terms of policies and governmental action?
So one of the benefits of being in a policy role is that I can help with my team to act as an icebreaker for community voices. And so one example is, for example, on bioethics. So we have an Ontario bioethics table that's supposed to help guide healthcare decisions and resource allocation decisions in this time of COVID-19. We also have regional bioethics tables that are supposed to do something similar at regional scales. And upon review of the first couple of documents coming out of those, we see there, there might be a mention of disadvantage or a mention of equity, but it's not specific to the lived reality of inequity and marginalization in Ontario right now. And so what we were able to do is reach out to those tables and broker relationships with community leaders with ethics expertise from marginalized populations. So for example, if you're Indigenous or if you're Black, you may not go to the hospital until it's very late into your healthcare journey because of a lack of trust with what you might experience there in terms of overt racism. We need to make sure that clinical guidelines and decisions take this into account so that when they're looking at what your pre-existing condition might be, what your existing symptoms of COVID might be, and so on, factor in the lived racialized realities for people. So that's one example. And then the same thing for people who use drugs. Again, we can use our voice at some of these tables to advocate for the prioritization of PPE because we've already seen overdose prevention sites having to close because of staff exposures to COVID, and that puts people at risk. So we can, it doesn't mean we have a lot of power, but we have some leverage, and we're trying to use it as well as we can. With respect to social isolation, we have developed good research and guidelines around social prescribing and the importance of social connection for people's health and well-being. And this is something that's emerging into the, what Paul Farmer, the anthropologist, would say, the consciousness and the space of the non-poor. And so, people who might not have considered equity issues before also find themselves in a place of isolation. And so recognize for the first time, perhaps, that something that many people have been facing for a very long time. And since we know there are health risks, government is looking to us to help advise on how do we reach seniors, how do we make sure supports and services are there, how do we help people access devices and so on. And so we're working constructively as much as we can with government to make that happen. When it comes to the migrant agricultural workers, again, what we're trying to do is help broker solutions that bridge boundaries. So there's a lot of confusion or finger pointing between what is the role of public health units, what is the role of the province, what is the role of Ontario Health provincially, what are the roles of the Ontario Health regional tables. And so it's quite confusing for people. And so part of our job is to help figure that out and request that we have the clearest possible situations and accountabilities for these health inequities. And so those are the kinds of things, as we go through the different kinds of marginalizations, where we're trying to do just that, to hook the right experts from community with decision makers so that they can be in there before having to be reactive. We need to take a preventive and precautionary approach across this pandemic, and in particular for people for whom we know there are already existing marginalizations and vulnerabilities.
Thanks, Kate. Roberta?
Hi, I'd like to add to that. Thanks, Kate and Angela. The local, provincial, and global Western governments are part of the problem and are accountable for providing solutions. They're intrinsically linked to creating and sustaining structural violence that leads to these intersectional health disparities and health violence. Resources and funds need to be given to communities and community members who are living and working with increased health disparities without little tied aid. For example, El Salvador right now, during COVID-19, El Salvador, which is called a so-called developing country, has given 3-month rent-free to everybody and given $300 US. And we are, supposed to be a country that is wealthy, and it's so complicated to get funds. Give us the money and we will support our communities. We need a rent freeze and public health to address health disparities. For starters, we need to collect intersectional data related to race and other health factors and realities, control media bias and violence, stop racial profiling, confront anti-Black racism in healthcare, and all other aspects of our lives, which now intensify during our crisis, test Black people for COVID, collaborate to support communities to deal with loss. There's so many people who are losing loved ones. For example, looking at food security via initiatives similar to the Black Creek Farm initiative, which is an amazing initiative. It needs to be funded, document and respond to the specific needs of those incarcerated and underhoused, to give a few examples in our communities. We need people to respond through funding, resources, and communities who have already established these relationships with our populations.
Thanks, Roberta. Andrew, what are your thoughts?
Yeah, and just to build on the comments of others, I have kind of 3 thoughts for government, 3 areas. The first is, COVID has led to a lot more transparency in some ways. It's led to real pressure for transparency, and governments have followed. And I think they should continue. I think the public has really benefited from that. Health providers and others have really benefited when government has opened the door. So continuing that, but then adding to it, actually collecting information about who is impacted. These are some simple things that could be begun, such as at COVID assessment centers and in hospitals, is collecting information about race, about income, and other characteristics, so we can start to pinpoint the disparities that have already been seen in the US and other places. So we can actually use that to pivot and say, wow, we're really missing groups, or we're actually doing a poor job with certain communities and we need to do more. So data and transparency around it. I think a second is, as I mentioned, is taking an equity, a lens approach, which could be fairly straightforward. We've talked about 8 to 10 different groups here. Indigenous individuals, those who are homeless, the uninsured, migrant workers. We've talked about those who are incarcerated, the working poor as a broad category of people who are very close to the poverty line but are continuing to work. Seniors who are isolated, and those at risk of intimate partner violence. So there's a subset of people we could just pose the question with each new policy or each decision is, how is this going to impact this community? And I feel like that's something straightforward that policymakers and public health officials who are working very hard on this issue could do. And then it would be, let's direct the resources to where they're most needed. So the third suggestion would be, let's actually make sure we're moving from a kind of a universal approach where, as you said, COVID seen as a great equalizer, we're all at risk. Well, no, it's more like COVID is the great revealer that has revealed social disparities that predate it and amplified them. And let's actually put more resources to the greater, to where they're needed most. An interesting example that I think was just recently announced was the Ontario government offering $200 to every family that has a kid under the age of 12. And I think that's important to get the funding right into people's hands, but some families need a lot more support than others. And let's think about that. And I think that would be, a disproportionate universalist approach that would actually put more resources to those who are at greater risk.
Thanks, Andrew. So we have about 10 minutes before we're going to open up, and we had a third question, but I'm going to kind of alter the way this is framed. So one of the things that's been remarkable about this pandemic is that it's brought into tension two of the core missions of public health. So public health has that health protection mandate, which we talked about last week, that it has the power to enact policies to protect the spread of health in the community. But public health has also been the champion of concern for the social determinants. So there's kind of an internal tension within public health. So one of the issues around public health and social justice is that and we were getting to this when people are, Andrew, and you were suggesting, and I think that all other participants, that there might be a justification for redistribution and renewed focus on disadvantage, because the last thing you want to see is that the response to the pandemic actually worsens disadvantage rather than in some ways addresses. So Madison Powers wrote that the account of justice, of social justice, stresses the fair disbursement of common advantages and sharing of common burdens. And it captures the twin moral impulses that animate public health: to advance human well-being by improving health, and to do so by focusing on the needs of the most disadvantaged. So a kind of a really explicit prioritarian commitment to giving priority to ensuring that these communities that we're discussing are not worsened in their disadvantage in our response to the pandemic. So at this stage in the game, Angela, how would you see that playing out? I know you weren't planning to, this is a little bit off script, but what the heck?
Well, first I would see so part of the issue for First Nations in particular, and Inuit communities, and for some of the Métis communities, is that when the government says something, the federal government will say they're responding to it, or they'll say that it's a provincial government issue. So this is a quagmire that's been going on for 150 years. Nothing's been done to fix it. And right now, it's actually at its worst, because right now we're seeing that, right? So why are you not getting PPE into a community? Well, because the feds say it's the province's problem. The province says, well, wait a second, that's a Fed problem. Or, this is another ministry's problem. It's not mine. So we have to start looking at that, because that just further vulnerabilizes, I'm not sure if that's a word, but makes them more vulnerable. Second, I keep thinking about, whether it's between federal, provincial, or if we start thinking about the idea that First Nations have their own governance structures that have been negated and pushed back. And I think that we need to be talking about that. I was listening to what Andrew was saying, and one of the concerns I have about data collection, while I totally agree we need it, is how do Indigenous people actually keep hold of it? Because we have Indigenous data sovereignty groups who are saying this is fantastic to get us numbers, but we need to actually have control, because then things happen that make us even more vulnerable. So that would be my thought.
Kate, do you have any thoughts on this?
It's heartening to see the level of positive response that is coming, particularly from the grassroots. We are seeing people wanting to help one another, and people seeing things that were rendered invisible to them for various structural reasons for a long time. In my climate work, we often talk about resilience as a way of bouncing forward, not bouncing back. And I think it will be very difficult for us to bounce back to the way things were before, knowing how inequitable it was, knowing how unsustainable, how unhealthy, and not resilient that state of affairs really was. And not just for marginalized people, but everyone is at risk. When the most marginalized person is at risk, we are all at risk. And one of the main reasons is because we live on a planet, like we are biological creatures. This pandemic is a reminder of our relationship with animals, with nature, with the world, and the changes in our behavior around how often we're flying, lowered carbon emissions, different structures of work. All those things point the way to the recognition that all of this was possible. It just required the collective will and the political will. And we need more collective will and more political will to make sure that the responses are equitable and that they're sustainable, that we can keep them going into the long run. And the thing that gives me hope about this, in spite of the real inequities and the real risks faced by people, is the amount of helping that I've seen. It's an expression of love. It's an expression of solidarity. It's an expression of a willingness to be together, to be through this in solidarity together. And our own research on social prescribing has shown how healthy that is for people. That helping other people, particularly if you're the one feeling isolated or expressly experiencing marginalization, it can really help. It can help you and it can help your community. And so we have some huge challenges to overcome, but this does give me hope that when we all have the collective will, when we have the need, and when we see these expressions of neighborliness and solidarity, that we can do this.
Great, thanks. Roberta, any thoughts?
Just quickly, just in terms of the kind of notion of health protection and social determinants of health, yes, we talk about health protection, but how do we talk about it in the context of racial profiling for Black and Indigenous communities? We talk about social determinants of health, but we stress social economic status and not racism and colonization or colonialism. So what we stress in public health is very limited. And I think also even in language we use, we still call in communities visual minorities. We still say vulnerable populations, but not talk about colonial violence and health violence. We talk about the need for health reparations in the Black community and having actual funds to lead our Black health initiatives, to lead our own data collection, and to lead our own services based on anti-Black racism and colonial experiences. So I think, yes, there's a lot of things that can be done. And we have that knowledge and we have that history, and it's not being done in COVID-19. It wasn't done during HIV. It wasn't done based on Ebola and other incidents in the African communities. So what can be done is to actually decolonize our ideologies and practices and actually make the slogan that says, we're all in this the same, which is very problematic and rhetoric, make it practice by doing health equity and anti-colonial practice in all healthcare and all aspects of our life.
Great. Andrew, before we open up to the audience questions, any last thoughts on that question?
Yeah, and I know we want to get to the Q&A, which will be really neat to hear what people's thoughts are. I just want to echo what Angela said. I should say, whenever data is collected on any community, particularly within the Indigenous community, which has such a history of data being used against communities and to further colonization, that the community has to maintain control and possession of that. And I think the OCAP principles are a great guide for folks. So like when the upstream lab is making suggestions around data collection, we're always mindful of whose interests is it going to serve, and where will the control lie. The last point I'd just make is that I think now is the time for us to be planning for after COVID. What of these changes are we going to say we want to be permanent, and to actually become part of the social infrastructure? There's everything from examples like eliminating the requirement for doctor's notes, which is a great example for Ontario, where we had one government ban them, and then another government come in and reinstate it. And now again, the ban happened because of a crisis. Are we really going to see them come back? So that as one, but there are numerous examples. We've been able to quickly open up housing for the homeless. And could we envision truly doing that, like as other jurisdictions have done, actually say this is our opportunity to essentially eliminate homelessness and actually make sure people have a house? Is this a chance to also say that people need a proper income support, that there needs to be strong enough supports for people, that it doesn't need a crisis to generate this? So I feel like there's a need for communities to come together and prepare a set of demands that are, this is what we want to be staying around afterwards, after this is all over, and that we don't just accept that it was because of a crisis that we were able to rapidly strengthen the social safety net, but that we want this to stick around.
That's great. Excellent points all. And I think now people in the audience are starting to visualize and conceptualize how we can move forward and not repeat some of the dysfunctions in the past. So the first question, I think I'll put it to Kate first, and then have everybody chime in. How is this, has anybody looked at how COVID-19 is actually affecting populations with living with disabilities? Kate, I know you work with that. Would you?
Yeah. So yes, we have. It really speaks to that sort of eugenics of expendability, right? That there's a real concern that people living with disability or with chronic conditions or pre-existing conditions might be somehow considered more expendable or more vulnerable than others in this. And it plays out in a bunch of different ways. It plays out in increases in isolation. It plays out in caregivers being thrust into increasingly untenable situations on their own, trying to provide support either for elderly relatives or those with different kinds of physical and developmental disability. And it plays out in our long-term care facilities, for example, where people are alone and without their family caregiving support. Happily, the disability community is organized and has reached out on bioethics tables, for example, and in other means to make sure that that life is respected, and that lives are valued, and that this is something that's very significant for people. Certainly for people who are facing mobility challenges, that work of social prescribing, outreach and support, also for caregivers, anyone who's in that more isolated situation, I think they are beginning to receive some supports and services. But as Andrew has pointed out, these are, sort of grassroots and disjointed. We don't yet have a strong institutional, structural response to this. And we need those two. It can't all be grassroots helping one another. It has to be something broader.
Thanks. So Roberta, did you want to jump in there before I move to the next question?
I wanted to add something. I'm a person living with visual disability and other underlying conditions. And I think that the response also needs to be an intersectional one. And what I mean by that is that disability is not a homogeneous population or, a factor. That we have people who are living with disabilities coming from racialized Indigenous communities, queer communities, underhoused, etc. So it's not being addressed. I can say that from my perspective, that within our media we're talking about the notion, particularly the beginning of COVID, they talked about the notion of elder people having an underlying conditions. And it sounded like a kind of eugenics notion of who might get it and how we prepare ourselves, when in fact, many younger people have underlying conditions, et cetera. I know somebody whose cousin just passed away with COVID, who was a 16-year-old young girl living with Down syndrome and was not tested. It wasn't in Canada, but it's still connected to how people are treated. So I think having an intersectional lens in terms of disability and ableism in Canada is really important when we're trying to create solutions.
Great, thanks. So the second question kind of builds upon this, and maybe I'll ask Angela and then Andrew to respond. So are there any concerns about, for example, triage protocols and how these might actually lead to greater harm for more marginalized communities? Angela, would you like to?
Oh my God. So I don't know if everybody watching knows about Brian Sinclair, but there's a prime example of not paying attention to Indigenous people who go to a medical facility. I hate to say that that's still a reality. We still have huge Indigenous racism in Canada. I've experienced it, and I'm a lighter skinned First Nations person. So I don't even want to hazard a guess at how much that's going to cause problems across the country. And on top of that, it's not necessarily just healthcare, but like people are treating Indigenous people like we're throwaway, just like Roberta was just saying. And so what I'm seeing is that we're not getting the triage period because we're afraid to go to the healthcare professional because we're afraid that we're not going to get the service that we need. So I think that there's more underlying issues there.
Andrew, do you have any thoughts on this?
In terms of triage, we could think about it at two levels. There's at the kind of a high population level, which communities were really seen as a priority in the response so far, and as others have noted, there was an unstated but seemingly present sense that some communities were going to be sacrificed in this, which. Of course, nobody has said that explicitly, but if we look at people who live in shelters, there was just simply an acceptance until advocates strongly asserted that it's impossible for someone to physically distance in a shelter and that there's an urgent need to do something about it. But until those voices were heard, there was not a lot of action. There wasn't a proactive thought. Similar for Indigenous communities with PPE, as Angela has said. Similar to people who are incarcerated. So until people have said, if you have a COVID outbreak in these settings, it's going to be carnage, that there isn't that action. So that's, in this sense, that's the triaging is a lack of foresight, and also an unspoken feeling like some communities and some groups are almost expendable in this, which is horrible to say, but unfortunately how the policy has it seems has played out. And then at an individual level, this is more tricky, which is that we have to think about, where are we directing our resources? Like, where's the health system putting the resources, and are they taking an approach which is saying this person needs more of our time, more of our effort, and needs an integrated set of health and social supports to really get them through this. And how can we use the information that we have or could collect to actually inform that? That sort of what I'd love to see is where, when people are presenting to COVID assessment centers or hospitals or primary care, that there is some form of a process to assess the person's social situation as well as their health situation. And not only give them the public health advice or support on the biological, but also say what social supports do they need to happen as well.
Thanks, Andrew. So your response, did you want to pipe in there, Angela? Okay, go ahead, please.
Just as you're saying that's actually the Indigenous way of, when you're in an Indigenous First Nations community, often you hear them saying we need to do holistic services, like Andrew's saying, where it's more of a wraparound approach. We're not walking in and just what's your symptoms, what's your treatment, get out, next person. I know for a fact at Dewa Days, the Aboriginal Health Access Center in Hamilton, they do that. They actually sit there. It may take a half an hour to talk to the person, but they make sure that they're finding out everything. And that's hugely important, not just for COVID, but for everything. Because how are we ever going to help our most vulnerable? And I hate that word, because while we're vulnerable because somebody else put us in that position.
Yeah.
We're marginalized because somebody put us in that position. But for the people who are at most risk, we need to start thinking about how we do this holistically.
That's great. So Angela, your answer brings me back to work we did before H1N1, where we brought the so-called vulnerable populations together. We were doing a day-long response, and we had these communities, so the practitioners, the policymakers, the vulnerable people, and then they were going to speak, and everybody was going to listen. And the first thing they said is, we don't, thanks for inviting us and for considering us vulnerable, but we're going to resist. You do make us vulnerable. And so, Andrew, your answer to the question, the first part about triage at the population level, feeds in very nicely to the next question. So, what would an equity-minded public health response to the pandemic look like? What would it involve? Multiple situated interventions that take into consideration the special needs of particular populations? Who wants to feed that answer that one first?
I'll take that one.
Kate, go ahead. Okay.
So, I mean, this is for those of us working on health equity, a moment to share some of the work that we've been doing for a really long time. And certainly I've learned so much from Angela and Roberta and Andrew today about the work that they're doing and how much synergy there is between us. But yes, it requires multiple situated responses from the individual to the structural and across divisions, social and material. I think that we need to ensure that the responses also consider the ongoing non-COVID needs of all of us, so that we don't forget that people with complex conditions, medical conditions, and social circumstances continue to require the support and continue to require access to services. So that's something that will also continue to be really important as we consider this going forward. But I think one of the most important things is that the diverse voices need to be at the table. They need to be at the table for decision making so that we're not constantly reacting to decisions that have been made in our absence.
Great, thanks. Anybody else want to chime in there? Roberta, you look like you had something to say. Am I mistaken?
I just wanted to, I guess, echo Kate. Kate said a lot of the things I was going to share. It's really important in terms of, what would an equity-minded public health level response look like? Well, it wouldn't look like this, right? It would have had a proactive type of practice. We would have taken historical and current day health disparities into consideration. We would have, even in terms of testing, Ontario is still testing the least when we know we have the most diverse population, the most racialized, marginalized populations. We would have programs to test people, for COVID from racialized, marginalized communities. So I think that unfortunately, we're in a place where we are in a pandemic, and we're talking about these issues that we talked about before the pandemic, and we'll talk about after. I think we have to think about our health ethics, how we can create an anti-oppression health ethic. How we do things, how we practice things, how we decolonize our health. Structural violence. You look at our educational systems, look at our health systems, look at our housing security, food insecurity, all of these things. So it's a way, it's something that we do in, us on this panel, and lots of people who are working in these communities on a daily basis, and we need support for it. And we need not to be criminalized and to be marginalized, and to have our voices heard. Thanks.
You. Andrew, do you want to have a quick comment here? And then Angela wants to show us a graphic, and then we're going to have to tie things up, and we still have questions on the table. So Andrew, for...
Yeah, a quick point. I see one of the questions was about frontline workers. What can they do? And a thought is that for all of your folks who are coming in with any symptoms of COVID or concerns about COVID, that you also are asking about some key social challenges, including income, housing, food security, and risk for intimate partner violence. And then having in your back pocket kind of the local resources that could assist people. And again, the Upstream Lab's working to try to create a tool that would make that really easy for folks across Canada. But just having that ready, I think, would be really key. I'll just say that I agree with Roberta that I think we're in the midst of this right now. The thought is that we could update our pandemic protocols to incorporate this now. There's no need to wait. And I think a lot about how we train to respond to disasters. We actually always have a part of that procedure, such as a disaster like a flood or something of that magnitude, where we actually think about certain populations, and we think about how are we going to help the seniors who are isolated, how are we going to help others, so we can update our standard procedures around dealing with communicable diseases to factor this in.
Angela, any last words before we bring this to a close?
I was going to show a graphic just to talk about the social determinants of health when we talk about equity, and that there's more social determinants of health than there are the Health Canada 12. So colonization is one of them, racism is another. We don't talk about those. We pretend like they don't exist unless you're in a class, in a public health class, right? Like that's a reality. Just building from what Andrew said, I just spent the last week looking at the Canadian Pandemic Influenza Plan and the Ontario Plan, trying to help First Nations communities here in Ontario. And I can tell you that it sounds great for cities. Doesn't sound so good for rural areas, doesn't sound so good for anybody that's at risk or vulnerable. Certainly does not work for First Nations people. A lot of things slip through the cracks. And honestly, a lot of the things that we're experiencing that are problems, like running water, the overcrowding, the lack of adequate housing, all of those things, and improper or not enough healthcare, all of those things have been going on for like decades. This is not news. And yet, even though in those pandemic plans, they said that they needed to fix them, they came out in 2004 with SARS and we still haven't fixed it. So I feel as though there's a lot of lip service, but not a lot happening.
Okay. Well, I think we're coming close to a conclusion. Does anybody have any final thoughts that they would like to share before I thank you all and conclude? You've certainly raised some very, very profoundly important issues that going forward we're going to need to address. In retrospect, we should have addressed before we got to where we are now. A lot of work before us, and I think you've all provided some very tangible, concrete, and workable solutions for us to start working on as soon as we finish this webinar. Any last thoughts from anybody?
I just want to say I just support health justice for all and not just us action for a few.
Okay. Andrew, Kate, Angela, any last comments?
Just thank you to everyone who helped organize this discussion, and yeah, look forward to working with everybody on these issues.
Excellent. Well, let me thank you, Angela, Kate, Roberta, and Andrew, for taking time and for your very insightful comments. And I thank the audience also for joining us today. For those interested, next week's webinar will be on Wednesday at noon. It's going to be focused on equity, rights, and global health. It's being hosted by the Office of Global Health Education and the Center for Global Health at the Dalalana School of Public Health. And Erica Di Ruggiero will be the moderator. So in the meantime, I wish everyone to keep safe, to keep well, to keep sane, to wash your hands, to stand 6 feet apart in solidarity. We will get through this, and I look forward to meeting everybody in person at the nearest possible time. So thank you, and everybody be safe and well, and we'll see you next week.
Thank you.
Thank you.